Good morning. I welcome you all to the another edition of Online Anesthesia, a postgraduate teaching program on Zoom platform, sponsored by Arterial and hosted by A1 Today we begin with the cardiovascular system. We have Dr. Azam with us today to deliver lecture on the physiology of cardiovascular system. You all know Dr. Azam. His notes are famous among postgraduates. I used to refer his notes before taking classes for my postgraduates. I am happy to have him today. That lecture will be followed by my topic, that is on shock. Today's video section, there is a demo of setting up of the intra-arterial transducer by Dr. Sivaprasath. So I request Dr. Sivaprasath to introduce the first speaker, Dr. Azam. Over to you, sir.
Good morning and welcome to this session, all of you postgraduates. In this good morning, we are happy to see Azam sir live. You all would have read his notes. And today we have him live. We can see his face here. He is here to take a very interesting topic, that is physiology of cardiovascular system. Azam sir has a lot of interests in a variety of fields. His specialty of interest is in regional anesthesia. He is the executive chairman of IORA, you all would have been knowing. He also has special interest in critical care and obstetrics. So together, he has written a chapter of critical care and obstetrics and mechanical ventilation in textbooks, and his articles on pre-oxygenation are very interesting. So without wasting, he is the senior consultant in Bhagwan Mahaveer Jain Hospital. Without wasting much time, we are very eagerly waiting to hear his lecture. Welcome, sir.
Thank you, sir. Thank you so much, sir. Thank
you.
Yes. Can you guess who are these gentlemen? Right. On the left is Carl J. Wiggers. Carl J. Wiggers is famous for his Wiggers diagram. And he is Mr. Thomas Lewis. He's the father of electrophysiology. So Wiggers is the famous for Wiggers diagram, and this is what is Wiggers diagram. We will go in detail as we go further in our talk. Now, who is this gentleman? He is William Harvey. His greatest achievement was the demonstration of circulation of the blood. And this gentleman is William Habuden. He said something to do with the blood circulation in coronary arteries. And take a guess, who is this gentleman? He is Mason Soames. His contributions were coronary catheterization, percutaneous coronary intervention, and coronary artery bypass surgery. So with this, I would like to first congratulate Dr. Edward Johnson, sir, for creating such a wonderful platform for learning anesthesia for postgraduate students. I think it's one of the most noble thing what sir has done. Thanks to you, sir, and hats off to you. At the outside, I would also like to thank Dr. Edward Johnson, sir, for giving me this opportunity to speak on such a honored platform. So, sir has asked me to speak about cardiac cycle, coronary circulation, and pressure volume loops. So, this is quite a long topic. So, I'd request you to, bear with me. First, we will start with cardiac cycle. I request everyone to just pay some amount of attention here, because cardiac cycle has a lot of cyclic events that are happening one after the other. So what happens is, even if the concentration, or if you lose, one or two slides in between, you will lose the whole process of cardiac cycle. So I'd request you to concentrate for some time. It's not very difficult. Now, by definition, the sequence of electrical and mechanical events that occur in the heart during the single heartbeat is called the cardiac cycle. Now, what are the electrical events? The action potential that is generated in the form of ECG, and the mechanical events like systole, diastole, volumes and pressures, like pressure changes in the ventricles, pressure changes in the atria, volume changes in the ventricles, and valvular events like production of heart zones. So these are all the mechanical events. Now, if you see the graph, the pressure volume loop, it's only the left ventricle has been used. Now the question is, why is the left ventricle being used? The volume and the pressure changes are more in the left ventricle, and the right ventricle pulmonary artery, in right ventricle, the pulmonary artery, the right ventricle has to pump the pulmonary artery to the lungs, it's much easier and less resistance. But whereas the left ventricle has to pump the blood through the aorta, first it has to create a pressure where the aortic valves open, and then it pumps the blood to the different parts of the body. So the aortic pressure is about 80 millimeters of mercury, whereas the pulmonary artery pressure is about 8 to 10 millimeters of mercury. The maximum it can reach is about 25 millimeters of mercury. The peak left ventricular pressure, 120 millimeters of mercury, that is the maximum pressure that when during a ventricular systole, the ventricle can reach. So the pressure can reach. So the peak pressure of right ventricle is, as I said, maximum is about 25 mm of Hg. I think I mentioned the pulmonary artery pressure is 25. It's not the pulmonary artery. It is the right ventricle pressure that can reach to 25 millimeters of mercury. Right. So the duration of each cardiac cycle and its implications are, now the normal heart rate, any normal heart rate is anywhere between 60 to 100 beats per minute. So we take a mean, so it's say about 72 beats per minute. So we take a 60 seconds divided by 72 beats, it is about 0.8 seconds. So why is it so important to discuss the tachycardia or the duration of the heartbeat? As the tachycardia or the heart rate increases, there is a decrease in the cardiac cycle. That is first thing. The second, during the cardiac phase, during the tachycardia, the diastolic phase decreases more than the systolic phase. That's very important. And the most important is the endocardial perfusion happens in the diastole phase. And if there is tachycardia, the endocardial perfusion suffers. So this is one of the most important points during this. Now, essentially, there are two phases in cardiac cycle. That is systole, that is the contraction phase, and there is a diastole, that is the relaxation phase. Now, during each cardiac cycle, as I said, it is about 0.8 seconds. So atrial systole is about 0.1 second. Always remember the systoles have shorter duration and the diastole has a longer duration because the time taken to fill the atria or the ventricle takes a little longer time. So relaxation, that is atrial diastole, the duration is 0.7 seconds. And the ventricles, the ventricular systole is about 0.3 seconds and ventricular diastole is about 0.5 seconds. Now we'll see the atrial cycle, which is about 0.8 seconds. In that, we see atrial systole, which is about 0.1 second. So atrial systole starts from the peak of the P wave, and where the AV valves opens, the blood flows to the ventricles and also through the great veins into the atrium, and then it goes into the ventricle. So when there is atrial contraction begins, the 80% of the blood flows into the ventricle is by passive filling. So there is nothing, no pressure is required. Ventricle starts contracting, the AV valves open, the blood just flows into the ventricle. But additional 20% of filling of the ventricles is by atrial contraction. Right now, atrium contracts and top-ups the volume in the ventricle by about 20%, a small amount of blood, and this contraction is called as atrial kick. Now, this is very important because during tachycardia, as I said, when there is a tachycardia or when there is an increase in heart rate, the duration of the cardiac cycle decreases. At that point of time, the atrial kick comes into action. Now, normally the atrial kick is 20%, but during tachycardia, the atrial kick can increase to 30 to 40%. So that is what it is, implication. Now, this is what I was telling you, a Wiggers diagram. Any Wiggers diagram will contain heart sounds, electrocardiogram, aortic pressures, ventricular pressures, atrial pressures, and JVP. So JVP is here, that is in the form of CEP can be measured. And this is also the atrial pressure. We have the aortic pressure here. The blue one is the ventricular pressure. The ventricular volume is the red one. We have electrocardiogram and the phonocardiogram for the recording of the heartbeat or the heart sounds. There are lines here. So between the dotted line and the bold line, that is the isovolumetric contraction. Then we have ejection. There is the rapid ejection and the slow ejection. Then we again have diastasis phase. Then we have the atrial systole somewhere here and here. Again, it is between the dotted line and the bold line. So we will see in our slides in detail about what is its importance. Now, today's discussion, whenever we're describing pressure changes or volume changes in the left ventricle, these are the following headings that I would be going, or these are the following sequence that I'll be following. First, I will suppose, for example, if I'm discussing about atrial systole, I will first discuss, yes, atrial systole starts from where and ends where, what happens, what are the ECG findings in atrial systole, and what are the heart sounds that, if at all, if it is there, what are the heart sounds that we could hear. Then we discuss about the pressure changes in the left atrium, in the atrium and the ventricle, and left ventricular volume. We will see changes in the left ventricular volume. Then we will see aortic pressure changes and the change in the JP. So this is the same sequence we would follow. Now let us see what happens to the pressure changes during atrial systole. Now, the pressure changes during atrial systole, we all know that right atrium is 4 to 6 mm of Hg, and the left atrium is about 4 to 8 mm of Hg. Now, let us see during atrial systole, that is the dotted line, is somewhere here, and the bold line. And if you see here, it is between the dotted line and the bold line is the atrial systole. So the P wave on the ECG, is because of atrial systole or a atrial depolarization. So it basically starts, if you see the dotted line, it passes to the peak of the P wave. So from the peak of the P wave is where the atrial systole starts, right? That is one thing. Then where does the atrial systole ends? It ends at the peak of the R wave. So it ends at the peak of the R wave or the peak of the QRS complex, you can say as well. Now, at this point of time, there is mitral valve here, as you see in this picture. So this is also the atrial systole. This is the atrial systole. There is mitral valve here. The closure of the mitral valve produces the first heart sound, not to forget, and it would be picked up on the phonocardiogram. Sometimes in few individuals, you also can hear fourth heart sounds. That is probably in this phase where the atrial systole is there. Sometimes it is loud, sometimes it is not. If it is loud, you need to think of pathological conditions, right? So the fourth heart sound is created. Why? Because it's created by the vibration of the ventricular wall during the atrial contraction. So that is responsible for the S4. So what are the implications of fourth heart sound? Right, as I said, the fourth heart sound sometimes can be pathological, and it is hypertrophic congestive heart failure. You can hear it in hypertrophic congestive heart failure, massive pulmonary embolism, tricuspid incompetence, or pulmonary. Now, let us see the left ventricular volume during the atrial systole. If you correlate this on the Vigor's diagram, it is here in the red ventricular volume. There is mild increase in the left ventricular volume because the passive filling and the atrial is contributing about 20%. So if you see this graph in the atrial systole, there is an initial increase in pressure, right? And the atrial kick comes into action and then it gets stabilized. So there is a mild increase in the left ventricular volume. Now, what happens to the aortic pressure during atrial systole? If you see the aortic pressure, there is absolutely no changes. Always remember the aortic pressure is between 80 to 120 millimeters of mercury. So it never touches zero, and it has no changes because there's no blood is getting into aorta. Now coming back to the left pressures in the left atria and the left ventricle during atrial systole. Now here the atrial pressures are there and the ventricular pressures are there. So the left ventricular increase will be slightly more than the left ventricle. If you see during the atrial systole, that is here, you see the gray line, which is slightly more than the blue line. So the gray line is atrial pressure, the blue line is the ventricular pressure. So it is slightly more than the line because the atrial systole is happening. And it is very close because the blood is going through the to the ventricle, so the pressure in the ventricles begins to start increasing. So they are very closely related. Now, what happens to the JVP? Okay, we do see a wave on the JVP during atrial systole, and this A wave is seen due to atrial contraction causing back pressure on the veins. So what happens when the atria is contracting? There is a back pressure that gets reflected to the veins. These veins do not have valves. So these do not have valves. So the pressure gets carried, the back pressure gets into the veins, and you can see a wave on the JVP tracing. Now, diastole phase, atrial diastole, it is 0.7. It just relaxes. There is nothing that's going to happen here. As soon as the atrial systole is over, this is the diastole, the bold line. So nothing happens. It touches almost the zero, right? And pressure gradually, then after that, it increases because the blood starts to trickle into the atrium. So atrium contraction is over. Now atrium is relaxing. Why atrium has to relax? Because the blood has to come back to the left atrium, right? Now, this is the most important. So I request you all to have a little bit of concentration here, because ventricular cycle is what major pressure changes happen. It is also equally important during your pressure loops. So ventricular cycle, as I said, will last about 0.8 seconds. After the atrial contraction is over, the ventricle starts contracting. That is a normal process. The ventricle gets excited by the impulse traveling along the conduction system. Now, what are the phases during ventricular systole? Essentially, there are two phases. It has two phases. So isovolumetric contraction phase, which is about 0.05 seconds. It has a phase of ejection. Again, the phase of ejection, which is about 0.25 seconds, gets divided into two. That is rapid ejection phase and the slow ejection phase. That is 0.1 second and 0.15 second. Now, this is the most important part, because it's not only important here, but also important in the pressure volume loop, because that is the time where a lot of your Viva questions, they ask you to draw in the exam. So please pay some concentration here. So what are the pressure changes during the ventricular systole? First, we need to understand what is isovolumetric contraction. Whenever we say isovolumetric contraction, it means what? Isovolume contraction. So the volume remains the same, but the pressure increases, because this is the time where the atria has finished, atrial systole is finished, and the whole blood has gone into the left ventricle. Now the pressure increases in the left ventricle, the AV valve closes, right? At this point of time, all the valves are closed. The AV valves are closed, the semilunar valves are closed. There is no blood going out or coming in. So the volume remains the same, only the pressure has to increase. Now, why is the pressure increasing? Because it has to force open the aortic valve. So once the pressure increases to about, say, 80 and above, the aortic valve opens and the blood gets ejected into the aorta. So isovolumetric contraction is one where the volume remains the same, but the pressure is increasing. Now, what happens in respect to ECG and heart sounds during isovolumetric contraction? Now, the isovolumetric contraction is just the small thing there, the dotted line and the bold line. So that means here, okay? It starts at the peak of QRS complex. So the atrial systole ends at the peak of QRS complex, and the isovolumetric contraction begins at the peak of RS. So you see it raising up. QRS complex, peak of QRS complex is where it begins, isovolumetric contraction begins. So, and we can also say that it starts with the closure of the first heart zone. This is the point where the mitral valve closes, because the pressure in the ventricle starts increasing, the mitral valve closes, the first heart sounds begin. When I say mitral valve, it also means the tricuspid valve as well. So the AV valve closes, right? Now, what happens to the pressure in the left atrium and the left ventricle during isovolumetric? The pressure is this, the blue and the gray. So the left ventricular pressure increases abruptly. As I told you, as soon as the valves are closed, the aortic valves, the semilunar valves, there is no blood going in, the blood is coming out. There is a pressure that has to be created in the left ventricle to open up the aortic valves. So the pressure, see the blue line, how does it abruptly increases in this phase? That is what happens in the left atrium. So the pressure increases very abruptly. So, but what happens to the left atrium? The left atrial pressure decreases. Obviously, the left when atria is increasing pressure, I mean the ventricle, where the pressure is being increased in the ventricle, the atria has to relax. So if you see in this, though there is a slight increase just because of during diastole, the blood is trickling into the atrium, and slowly the volume and the pressure starts increasing, and you can see a small increase during the isovolumetric contraction. Then what happens to the left ventricular volume during isovolumetric contraction? As I told you, there is no change in the volume. It is isovolumetric. So if you see this red line in this phase, then it is just flat. So there is no change. So no change in the left ventricular volume. Now, aortic pressure during, what happens to the aortic pressure? So aortic pressure also does not change because there is no blood going in, because isovolumetric contraction where the pressure is increasing, but it has not increased to an extent where the aortic valve opens, right? If the aortic valve opens, that is the point where the isovolumetric contraction phase ends. So in this phase, if you see here, there is no increase in any pressures because there is no blood flow into the aortic valve. How do we correlate with this with the JVP? So what happens is a C wave is seen again because now the pressure is being increased in the aortic valve. So what happens when the pressure is increased? The tricuspid valve bulges. Okay, the tricuspid valve bulges. So the slight pressure increases in the right atrium, and that again causes back pressure, and we see the tracing C. You can exactly see the rise in the JV, that is C, indicated by letter C. So to summarize, start of the peak of QRS complex, that is isovolumetric contraction, starts with the closure of mitral valve, that is the first heart sounds, ends with the opening of aortic valve, as I told you. So ventricular pressure more than aortic pressure, ventricular volume is the same. Isometric contraction. There's one more word called isometric contraction. Here, the muscle length remains the same. Only the tension changes in the muscle. Please remember this. So the ventricular pressure rises abruptly from 0 to 100 because it has to force open the valve. The maximum pressure it can reach is 120 millimeters of mercury in the left ventricle and 0 to 10 mm of mercury in the right ventricle. All the valves are closed, as I said, and aortic blood flow is nil, and you can see a C wave on the JVP. Right. I hope this clears the ventricular system. Now, what happens is the next phase, isovolumetric contraction. So the next phase is the phase of ejection. Again, phase of ejection said it divides into two, which is last about 0.5 seconds. So rapid ejection phase and the slow ejection phase. So what we have spoken is right now is isovolumetric contraction phase. Right. Let us see what happens in rapid ejection phase. ECG, just the ST segment. Now, rapid ejection is from the time the aortic valve opens, the blood gets ejected into the aorta, and the ventricular pressure also increasing. So at this point of time, that is the ST segment is what you see here. So ST segment on the ECG, we don't hear any sounds in the heart. Pressure in the left atrium and left ventricle, atrial pressure falls initially. So atrial pressure falls, then slowly increases. And because the left atrium receives blood during diastole, right, the ventricular pressure increases, but the aortic pressure is more than ventricular pressure. At this point of time, what happens is the pressure, which is about 80, now the ventricular pressure has reached to about more than 80. At that point of time, the aortic valve opens. Once the aortic valve opens, the pressure in the aorta first, it increases. It increases so much so that the aortic pressure is more than the ventricular pressure at one point of time. So what happens to the aortic pressures? Right, aortic pressure increases and there is steep increase in the aortic blood flow. So the blood flow the ventricle has to push in as much as blood into the aorta. So here you can see them, on the graph where the aortic pressure is increasing or increased. The left ventricular volume again, because the volume that is there in the left ventricle is getting into the aorta, the volume in the left ventricle starts decreasing. So there is steep fall in the ventricular volume by about 2/3. This is exactly what happens. So this is the initial rapid ejection phase, and then there is a slow ejection. So what are to summarize the events in the phase of ejection, it starts with the opening of aortic valve because ventricular pressure has to overcome the aortic pressure. Lesser duration because it's rapid ejection, aortic pressure increases, ventricular pressure increases, but the aortic pressure is more than the ventricular pressure. Atrial pressure falls initially and then slowly increases because the atrium receives the blood during the diastole. There is steep fall in the ventricular volume and steep increase in the aortic blood flow. And when it compared to the ECG, it is ST segment seen on the ECG. Now, the last phase of ventricular systole is the slow ejection phase, which is about 0.15 second. What do we see on the ECG and the heart sounds? Yes, we do see T wave. So this T wave is on the later part of the ejection phase. That is called as the slow ejection phase here. Though the blood is being ejected, but it is not as much as what the rapid ejection phase, but slowly the momentum of blood keeps going in. That is during the slow ejection phase. So we see the T wave on the ECG. Then what happens? The atrial pressure continuously increases due to the atrial filling. So what happens here in the atrial pressures during here, it starts increasing. If you closely watch here, there is slight increase from the baseline. It moves up because now atrial pressure continuously, because the atria keeps getting filled now, okay, and the pressure in the atria starts increasing, and the ventricular pressure and aortic pressure decreases. So at the same time, the ventricular pressure and aortic pressure decreases, where the aortic pressure does not come and touch zero. It stays by about 80 millimeters of mercury, because it has to close. If it doesn't close, again, the return of the blood from the aorta again to the ventricle, again, that means the aortic regurgitation is happening. So aortic pressure during the slow ejection phase, as I told you, the ventricular, this we have finished. Okay. So the left ventricular volume during slow ejection phase. If you see in the slow ejection phase, ventricular volume further decreases, okay, because the 2/3 has gone in the first stroke of the ventricular systole, and the remaining 1/3 of the blood is again being ejected out of the ventricle. So that is what you see here. It keeps on decreasing, but it is going to be in a slow fashion. So to summarize the slow ejection phase, longer duration, ventricular and aortic pressure decreases, aortic pressure more than the ventricular pressure, aortic valve opens, blood flows to the aorta due to momentum of the blood, aortic flow decreases, the ventricular flow further decreases, and the atrial pressure continuously increases due to atrial filling. And you can see T wave on the ECG, and the phase ends with the closure of the aortic valve. Now, what are the volume changes in the ventricle? Stroke volume is about 70 to 90 ml. Left end diastolic volume is about 130 ml. That is the volume left in the at the end of the diastole. That is about 30 ml. That is the amount that has to push into the aorta. The end systolic volume, that is after the systole is over, what is the volume that is left? That is about 50 ml. And ejection fraction, at least 65% of the end diastolic volume should be ejected out in every stroke or in every heartbeat. So what is stroke volume? About 70 to 90 ml of blood that has been ejected out by each ventricle during each systole is called as stroke volume. So what is end systolic volume? As I told you, about 50 ml of blood is left in each ventricle at the end of each systole, and this is called as end systolic volume. The same thing during ventricular diastole, the ventricular volume is about 130 ml, and this is called as end diastolic volume. So let us see what is ventricular diastole. It has two phases. One is pro-diastolic phase. Many books says there is a phase called pro-diastolic phase, and many books don't say this as well. It is about 0.4. As I told you, the diastole phase is much more longer than ventricular systole. So 0.5 seconds. Isovolumetric relaxation. How the isovolumetric contraction happens, here the isovolumetric relaxation happens. So this is also very important during dealing with our pressure volume loops. So there's ventricular filling phase, rapid and slow filling. Pro-diastolic phase, this is when the ventricle systole ends, the ventricle starts relaxing, already falling ventricular pressure decreases more rapidly, and it ends when the momentum of blood overcomes. During this phase, there is elevated pressure in the distended arteries, that is aorta and pulmonary, which pushes the blood back towards the ventricle, which snaps the semilunar valves to close, and aortic and pulmonary valves closes, right? And this is the time where we hear the second, when the aortic valve and the pulmonary valve closes, so we get to hear the second heart sounds. So we will see what is isovolumetric relaxation phase. This phase starts at the closure of aortic valves. So closure of aortic valves, when we say closure of aortic valves, it is not only aortic valves, also the pulmonary valve as well. So whenever we close, there is a closure of the aortic valve, this phase is started. Which one? The isovolumetric relaxation. Now the rapid decrease in the ventricular pressure happens. Okay, so ventricular pressure rapidly it decreases. Suddenly, if you see here, it decreases. This is the isovolumetric relaxation. So you can see the pressure getting decreased or being decreased. No change in the ventricular volume. So again, there's no change in the ventricular volume in this phase, right? Then aortic blood flow is nil. Again, aorta, you will not have any increase or decrease. It is the same, maintained at about 80 millimeters of mercury. We said that aortic valves closes, so the second heart sound is produced and atrial pressure increases. Now, if you see the atrial pressure, there is slight increase in here, okay, and we see a V wave is seen again because of the back pressure. As I told you, the atria, there are no valves in these veins, so there's a back pressure, and you can see a recording of V on the JVP. So there is something called incisura. What is incisura? At the closure of the aortic valve, you see a dicrotic notch. This is here the dicrotic notch. Okay, and in the downslope of the aortic pressure, which is called as incisura. Okay, now rapid filling phase again, it is last about 0.11 seconds. So mitral valve opens, again increased ventricular volume, pressure decreases in the ventricle in spite of filling, decreased left atrial pressures, and here you can hear the third heart sounds. That is because of rapid rush of blood from the atrium to ventricle. So there is rapid initial flow of the blood in the ventricles. You can hear the third heart sounds. What are the implications of this third heart sound? Third heart sound again is a pathology, could be pathological. So seen in dilated congestive cardiac failure, severe hypertension, myocardial infarction, and mitral incompetence. Now we will see this ends the cardiac cycle. So we'll go into the coronary circulation. I will not go into detail because of the time constraints, but however, I will highlight the most important points. Now, the heart has the highest oxygen consumption per tissue mass of all the human organs. At the resting coronary blood flow is about 250 ml per minute, that is 0.8 ml per minute per gram of heart muscle. This represents 5% of the cardiac output. So ischemia results because of the oxygen demand supply, basically. Right, now let us see what is the anatomy. There are two coronary osteas, right? There is one here and there is one there, right? The two coronary ostia arises from the sinuses of Valsalva, just above the aortic valve. And there is absence of anastomosis between the left and right coronary arteries. Coronary arteries get perfused during diastole. Very, very important. Coronary arteries get perfused during diastole. Now, there are two coronary arteries, that is left coronary artery that gets divided into left anterior descending artery and left circumflex artery, and we have right coronary artery. Now, right coronary artery, this is what it is. We have the right main here. This is the mid right RCA, and that is right coronary artery, and we have distal right coronary artery. So again, to name some branches, this is the branch to conus. This is the proximal. This is the branch to node. Then we have right ventricular branch. We have acute marginal. Then we have posterior descending. We have left ventricular branch, and we have branch to AV nodal. Right. So this is the right coronary artery. So where, as I told you, the left coronary artery gets divided into left anterior descending and left circumflex. So this is the proximal circumflex. This is the atrial branch. This is obtuse marginal branch 1, obtuse marginal branch 2. Here we have posterior lateral branch. When it comes to left anterior descending, we have the first septal perforation, then we have first diagonal, then second diagonal, and the distal LAD. All right. Now, what all it supplies? So left coronary artery, again we said it supplies the left atrium, the ventricular septum, that is anterior 2/3, left ventricle, that is septa, anterior and lateral wall. It has SA node supply, that is left anterior descending in 40% of the individuals, right? AV node, that is left circumflex artery in 10 to 15% of the individuals. The left anterior descending supplies septum and the anterior wall, that is the left circumflex, the lateral wall, and the bundle of his, that is dual blood, the bundle of his gets dual blood supply by the posterior descending artery and the LAD. Anterior papillary muscles of the mitral valve are supplied by the diagonal branches of the LAD plus the marginal branches of circumflex. Posterior papillary muscles has only one supply of the posterior descending artery and it is prone for ischemia. Now, right coronary artery again supplies the right atrium, right ventricle, atrial septum, the posterior 1/3 of the interventricular septum, SA node in 60% of individuals, and AV node in 85 to 90% of individuals. There are a few interesting facts about the coronary circulation. 5% of the cardiac output it goes to the coronary circulation. The total number of heartbeat is roughly about 1 lakh per day. If you calculate, it comes to about 8,000 liters per day that has been pumped out. It has 4 valves, 4 chambers. It has 4 valves and 2 septums, 2 great arteries and 2 great veins. Right? This is the most interesting, again, the interesting fact about the myocardial oxygen supply. The myocardial oxygen consumption that is in a cardioplegic heart is about 2 ml per minute or 400 grams. The normal myocardial oxygen consumption is in normal heart is about 8 ml per minute, that is per 100 grams. And myocardial oxygen consumption in heavy exercises increases to about 70 ml per 100 grams of tissue. And myocardial oxygen extraction is 75 ml. So what you see is, though the extraction is to its maximum 75%. So if you don't take care of oxygen supply when the demand is very high, that is a time when they get into cardiac arrest. The major determinants of coronary this thing is coronary perfusion pressures, myocardial oxygen balance, myocardial metabolism, there is neural control. So I will not go into all the details again due to time constraints, but however, coronary perfusion pressure is nothing but CPP, that is arterial diastolic pressure minus left ventricular end diastolic pressure. So again, how we correlate what coronary, which coronary artery supplies which part of the heart, and how it is implicated on the or depicted on the ECG. So when we see any changes in one AVL, V5, V6, it is lateral wall, most probably the circumflex artery. When we see 2, 3 AVF, inferior wall, right coronary artery. When V1 and V2, it is septum, left anterior descending. V3 and V4, anterior wall, left anterior descending. So the same thing is here. The circumflex supplies lead 1, AVL, V5, V6, right? V1, V2 is left anterior descending. 2, 3 AVF, that is inferior wall, right coronary artery. Now, this is the most important question asked in the exams. And this form of writing is called as mind maps, particularly important from the exam point of view for the exam students. The data says that if you learn in this fashion of mind maps, it's much easier to learn and reproduce faster in the exam. So this is called as mind maps. Try and draw this in your answer sheets. It's much more easier to write, very less time consuming and easy reproducible. So myocardial oxygen balance, again, oxygen supply, it depends on oxygen carrying capacity of the blood. And again, that depends on hemoglobin concentration, shape and position of ODC, hemoglobin saturation. And the coronary blood flow, again, aortic diastolic pressures, autoregulation, intramyocardial pressures, heart rate, coronary stenosis, collateral circulations, and blood viscosity. When there is demand, there are major determinants and minor determinants. So major determinants are like heart rate, contractive, wall tension, preload, afterload. And when it is about minor determinants, basal oxygen requirement, activation of energy, extent of work. So this, I think, finishes the coronary circulation. We will go to the pressure volume loops. In this, I will share my screen in a minute. Yeah, I have shared my iPad screen for the pressure volume loops. So we will be discussing the pressure volume loop, right? Now, the pressure volume loop depicts the sequence of events that occur or occurring in normal cardiac cycle in the left ventricle. In fact, the pressure volume loops are the excellent tool for visualizing the changes in the left ventricle. We have already spoken why we are dealing with the left ventricle. Okay. So, because the pressure changes are much more in the left ventricle. All right. Now here, I will label this as A. Let me use a different color so that it will be easier for understanding. A, this is B. This is C, and this is D. All right. So I was telling you why left ventricle, because the pressure changes are much more in the left ventricle as compared to the right ventricle. Now on the x-axis, that is on the x-axis, we have volume, that is left ventricular volume. On the y-axis, we have left ventricular pressure. Anything that moves up means increase in pressure. Anything that moves down is decrease in pressure. And anything that moves right is increase in volume. Anything that moves left is decrease in volume. Okay. Now, having said this, the before we start off the discussion, so for understanding, one loop is equals to one heartbeat. But other interesting point of pressure volume loop is the graph moves anti-clockwise. So from A to B, B to C, C to D, and so on. Okay, these are the basics that we need to know before we go on. Now, what happens is, okay. So what happens is, this is the point where the mitral valve opens. Okay, when the mitral valve opens, the blood starts flowing into the ventricle, into the left ventricle, and this is called rapid filling. And this is done by passive. There is no force involved. Fine. Okay. And once this is done passively, as it is done passively almost till here, there is a atrial kick. That is rapid filling. Rapid filling phase. And this is called atrial kick. The atrial kicks comes in here, and you can see a small increase in the pressures in the left ventricle. Oh, I mean in the volume in the left ventricle. So that is one thing that we need to keep in mind. The atria squeezes out the blood from the left atrium to the left ventricle. Hence, there is increase in the pressure. Fine. Once we know what is that, then what happens here? The point A is nothing but where the mitral valve closes. Point A is nothing but mitral valve closes. When I say mitral valve, that also means the tricuspid valve also closes. And because of the tricuspid valve closes, there is a first heart sound is heard. Heart sound is audible in the form of lum. This is one important point that you need to keep in mind. At this point, the ventricle starts. So this point, the ventricle starts contracting. So the problem is here the mitral valves are closed, the aortic valves are not yet open, neither the pulmonary valves are open, none of the valves are open. Neither the volume is coming in or going out. So what happens? The pressure in the left ventricle starts increasing. It has to increase to a certain level. That's what we learned in cardiac cycle. That is, it should at least reach about 80 and above millimeters of mercury to kick open the aortic valve. So once the pressure reaches the more than the aortic valve opens here. So point B is aortic valve. So A is mitral valve closes. Here aortic valve opens. The phase between A to B is called as isovolumetric contraction. So that is what we need to remember. So the point from A to B is called as isovolumetric contraction. Why it is called as isovolumetric contraction is because the mitral valve closes at point A. The aortic valve is not yet open. The pressure increases because, as I told you, any line that moves up on the y-axis, pressure increases. But as you see, there is no increase in any volume because there's nothing happening on the x-axis. So this is called as isovolumetric contraction. Now, once the isovolumetric, once the aortic valve opens, the ventricle starts contracting. So as the ventricle starts contracting, now the mitral valve is closed and the aortic. So once the left ventricle is contracting, the blood is going to get ejected out into the aorta. So it is called as ejection, systolic ejection. So this is rapid ejection phase. This is slow ejection phase. Okay. So this is called as ejection. So once the mitral valve, just to just tell you from starting, from point A to point B is called as isovolumetric contraction. So A is mitral valve closes, the pressure starts increasing. There is no change in the volume, neither the blood is coming in nor the blood is going out. As the pressure increases, when it reaches more than 80 millimeters of mercury or 80 millimeters of mercury, this is the point where the aortic valve opens and the left ventricle contracts and the blood is ejected out into the atria. Okay, so the blood is pushed into the atria. Now the blood is moving all along the x-axis. Okay, I said it move if the curve moves towards the left. So first there is increase in the blood getting into the aorta, then it starts decreasing. Okay, this phase between B to C is called as systolic ejection phase. I hope this is clear. Now, once the pressure starts falling down in the aorta, that is about, say about maximum, it is about 120 here and minimum at about 80 millimeters. So this is in terms of millimeters of mercury and this is in terms of ml. Okay. When the left ventricle starts relaxing, the pressure in the left ventricle starts falling. So this is how it falls here on the C to D. So this is the time where the pressure is falling. Again, there is no change in the volume. So there is no change in the volume. The pressure, the line goes down on the y-axis. So when the line goes down, that means the pressure is falling down. This phase is called as isovolumetric relaxation. Okay, the volume in the left ventricle does not touch the y-axis. Now, if you see, the volume in the left ventricle does not touch the y-axis. So say it is about 50 ml. Okay, so it does not touch the y-axis or zero. There will be some amount of volume that is left behind in the left ventricle. In this case, it will be about 50 ml. And also notice the aortic curve does not touch. This does not touch here. All right, because the aorta does not come back to zero. The minimum pressure that is maintained in the aorta is about 80 millimeters of mercury. All right, so the volume of the blood in the left ventricle during diastole is called as end diastolic volume. So end diastolic volume is this. So this is end diastolic volume. So end diastolic volume is nothing but end diastolic volume is nothing but the volume of the blood that is in the left ventricle during the diastole phase. So just before contraction, the amount of volume it is say about 130 to 120 to 140 millimeter volume ml. So it is told in terms, it's said in terms of ml. So the volume of blood in the left ventricle during the diastole is called as end diastolic volume. Okay, at this point of time, as I told you, the mitral valve closes and this creates the first heart sounds. Okay, the amount of blood, okay, the amount of blood in the left ventricle at the end systolic is called as end systolic volume. Okay, that is here, end systolic volume. This is end. Okay, this is the end systolic volume. So now you can take either C as end systolic volume or it doesn't matter because the only pressure changes, the volume does not change. Okay, so that's called as end systolic volume. And as I told you, there is closure. This is the closure of the aortic valve. So the closure of aortic valve means there is creation of the second heart sound. So second heart sound is heard now, and it is in the form of dub. Clear? All right. So point A to point B, this is the systolic phase. Okay. In fact, point A to B to C. So the whole thing is systolic, and C to A is diastolic phase. Always remember. Okay. Now, this pressure volume loops helps us to calculate the pulse pressure. So what is the pulse pressure? Say we take the highest pressure here, we take the highest pressure here. So this is the systolic pressure. This is the diastolic pressure. In this case, it will be about 80. In this case, it will be about 120. So 120 minus 80, that is the pulse pressure. That is about roughly about 40 millimeters of mercury. That is also one important thing. So you can calculate the pulse pressure just by the pressure volume loop. You can also calculate the stroke volume. The pressure volume loop represents the stroke volume by its width. So I will change the color here. So this is the stroke volume. Stroke volume is nothing but end diastolic volume minus end systolic volume. That is also, it will help you in identifying the stroke volume here. So in this case, in our case, say about, if you have to calculate about stroke volume, that is 130 minus 50. So 130 minus 50. That will be roughly about 80 mm, roughly about 80 mm of kg. So you can also calculate, it also gives us the stroke volume. All right. Now, let us see a few examples. I will not be discussing all the curves. I will discuss about the aortic stenosis. So let us take aortic stenosis. Now, what happens in aortic stenosis? There is a this is the left ventricle, right? This is the aorta that is going in from the left ventricle. Okay. This is just a pictorial diagram, so please bear with me. Okay, this is the left ventricle. Now, there is aortic stenosis. So what is aortic stenosis? There is this valves are very, very, very stiff. So they're very, very stiff. All right. Okay. Now, the pressure here in the left ventricle has to overcome this stiff aortic valve. Okay. So it has to do a lot of work. So this is nothing but left ventricle, and this is nothing but aorta. All right. Now, in aortic stenosis, what happens is the left ventricle pressure increases. So there is increase in pressure in the left ventricle. So there is increase in the end systolic volume. There is decreased in the, now what happens is to open up the aortic valve, the ventricular pressure has to overcome the aortic pressure, and then it will open up. So when these open up like that, then the blood gets in. Now, since there is a stiffening of the aortic valves, the ventricular pressure has to do a lot of work to open up. So the isovolumetric contraction phase will be prolonged. I will show it to you on the PV graph how it looks like. But however, not the whole volume goes in because the aortic stenosis is present. So what happens is some amount of blood will get into this, and the pressure decreases, and then so on happens. So what happens is there is decrease in stroke volume. All right. So there is increase in afterload as well. So there is the increase in afterload, there is decrease in stroke volume, there is increase in the end systolic volume, and there is increase in pressure. If you have to plot this graph, now we just here see the length of the isovolumetric contraction. If you compare to this, see the first of all, there is the isovolumetric contraction phase is increased. That is increased. The stroke volume is decreased. So as I told you here, this represents the stroke volume. When the width is decreased, that means stroke volume is decreased. When the width is increased, that means stroke volume is increased. So this is a few things that you need to keep in mind. So what happens is here, the aortic valve opens here, mitral valve is closed. This I said end diastolic volume, which is much this is end systolic volume. So there's no much change in the end diastolic volume. But if you see the end systolic volume is increased, instead of 50 ml, it might be more because there is a lot of blood remaining in the ventricle. The ventricle is unable to push across. And here is a point where AV valve closes. All right. So the aortic pressures also increases. That is exactly what we see in the cardiac cycle and also in now what we're seeing in the pressure volume loops. Here, the aortic pressure may go up to as much as 200 millimeters of mercury. So in aortic stenosis, because of the stenosed aortic valve, the ventricular pressure has to do a lot of work. So it has to overcome the pressure because unless the aortic pressure won't be 20, the aortic pressure is 20. So the ventricle has to pump much more than that to overcome these pressures to open up the aortic valve. Once this open up the aortic valve, then the blood gets ejected into the aorta, not the everything gets ejected. There'll be a lot of volume will be again retained back into the left ventricle. So there is increase in end systolic volume. So this is about the aortic stenosis. So now let us consider aortic regurgitation. So what happens in aortic regurgitation? There is, okay, now again aorta. Okay, now here the problem is the valves are very loose. Okay, the valves are very loose. Now this is LV, this is LA. We have a valve here, that is the mitral valve, and this is the aorta. Okay, fine. Now what happens is again, now there is aortic insufficiency, aortic regurgitation or insufficiency. So what happens in this is, now this ventricle has to do very less pressure because it does not have to come across the pressures in the aortic wall because the aortic wall is very loose. So they're almost open. It just has to push in the blood into the aorta. So there will be increase in the stroke volume, the first thing. So a lot of pressure has been applied here. Lot of pressure is applied here onto the ventricle, and then the stroke volume will increase. All right. Once the stroke volume is increased, there is increase in the end diastolic volume. Okay, and there is increase in the end systolic volume as well. End systolic volume. And what happens to the LV pressure does not do much work. So the pressures are much less as compared to the normal ventricle or aortic stenosis for that matter. So if you have just plot this graph, so here the end, this is the end systolic volume, which is increased. Here is the end diastolic volume. This is the stroke volume. Again, much more, the width is increased. The aortic valve opens, mitral valve is closed at this point, and aortic valve opens here, aortic valve closes here. Okay, so these are the few things that you will notice here. End systolic volume also increases. All right, and diastolic volume also increases, and the pressure, more importantly, the pressure decreases. So due to the time issues, we will discuss mitral stenosis. This is the one last thing I would like to discuss because it's very important from exam point of view. It is the much easier to interpret when compared to the other graphs. So the problem here is the end diastolic volume will be slightly, here is decrease in end diastolic volume very minimal. There is decrease in the stroke volume, okay, and there is decrease in the end systolic volume. Okay, if I have to plot a graph, it will be miniature graph. So a small graph here, which goes up. Now here, if you see the stroke volume is, decreased. The stroke volume is decreased. Okay, and again, there is stenosis here. Okay, there is no blood coming. The problem here is the blood coming into the left ventricle itself is decreased. So the question of the end diastolic volume is as such decreased. So there is no end diastolic volume. When there is no end diastolic volume, obviously your end systolic volume will be also decreased, and diastolic volume is decreased. Okay. And the pressures in the aorta also will be reduced. So this is what is in mitral stenosis. So what happens is all this, there is the left ventricle is normal. The functioning of the left ventricle is normal, but the problem is it impairs the filling of the left ventricle here. So there is decreased in end diastolic volume, or it's also called as the preload, right? That is one thing. Second, this leads to decrease in the stroke volume. Okay, this leads to decrease in the stroke volume by the Frank-Starling mechanism, and there is fall in the cardiac output. So when stroke volume is decreased, there is decrease in the cardiac output. Now, there is reduction in the afterload also, particularly aortic diastolic pressure. Okay, as I told you, the aortic pressure also is decreased. It will not be 80. It will not be. It will be much less than that. Okay, so there is end diastolic volume is decreased and systolic volume is decreased. So what happens is, because there is end diastolic volume decreases more than the end systolic volume, the decrease, the stroke volume also is decreased. That is what the mechanism is. So this finishes the talk. To summarize, first thing is it is important from the exam point of view. Okay, that is one. Second, the coronary circulation has been asked n number of times in theory and viva voce, not to forget. And then the PV loops, many a times the examiners have asked the student to draw the PV loop in the exam. Now, many a times these guys, the postgraduate students ask, sir, why do we need to know about cardiac cycle? The reasoning is it helps in therapeutic interventions. It gives us good understanding about the monitoring, helps in interpreting the data. So not to forget, coronaries get perfused during diastole. Fair to have good, and it is very important to have a good understanding about oxygen supply and demand in cardiac patients, because that is a single most event that can cause problems. And pressure volume loops gives us good understanding about the disease process. With this, once again, I thank Dr. Edward Johnson, sir. My apologies to take 10 minutes extra because I had to, explain the whole pressure volume loop in depth. I could not cut short, though I have skipped mitral regurgitation. Again, once more, congratulations to you, sir, for creating such a wonderful platform, and thank you so much for considering me for this. Thank you once again, sir.
Thank you, sir. Sivaprasath, sir.
Thank you very much, sir. It's a very exhaustive and wonderful lecture, sir.
Thank you, Edward Johnson, sir. Again, congratulations. I must, every time when I see this program, I get so excited to be a part of it. Hats off to you, sir, and really appreciate and hope the postgraduates take some amount of information from here. Thank you so much, sir. Once again.
Thank you so much, sir. Thank you.
There is one query about how to draw ECG and correlate with JBP, sir.
Shiva sir, like I said, it was asked in my exam. Like even the postgraduates must know about it. That's what I said, sir. It's not a query per se. Sir has explained that also.
Correct. Actually, I think, what madam was trying to say is, in the exams, you were asked to correlate with the ECG and JVP. That is why it is important to know the pressure volume loop and cardiac cycle. Sometimes the examiners will ask you to show where does the P wave come in, which part does QRS come in, which part is the ST segment and T wave. So thank you, sir. Thank you, madam, for bringing it up.
Thank you very much, sir.
Thank you, sir.
The next presentation is by Edward Johnson, sir. It's a very important topic, both in your exams as well as in your day-to-day management of your cases. Sometimes you may get stuck in a case where the patient goes in for a shock, many types of shock. Sir will enlighten us on the pathophysiology of shock and its role of vasopressors and anodilators. Over to Edward, sir.
Thank you, Sivaprasath, sir. Thank you, Azam, sir, for our wonderful presentation. And we are mesmerized with your presentation regarding the LV loops, sir. Excellently explained, sir. It will be more useful to the postgraduates. Thank you so much, sir.
Thank you.
So today my topic is the pathophysiology of shock and role of vasopressors and ionodilators. So if you know the pathophysiology of shock, then only you can understand the treatment for the particular shock. So I have nothing to disclose pertaining to this presentation. So the objective of my presentation is, and at the end of my presentation, you must be able to understand the pathophysiology of different types of shock and what determines the effective tissue perfusion and how to manage the shock and what is the role of vasopressors and venodilators in the shock. So the pathophysiology of shock. So shock is defined like this. So it is a life-threatening. Yes, it is life-threatening. If you leave the shock untreated, it will end up in death. So it is a life-threatening generalized state of circulatory failure. Yes, there is a circulatory failure to supply the oxygen and energy substrate to the need of the end organ. So that is the circulatory failure. So these are the 4 types of the shock. This distributive shock and hypovolemic shock concerned with the volume, and your cardiogenic shock and extracardiac or obstructive shock is concerned with the flow of the blood in and out of the heart. So coming to this distributive shock, there is an intense vasodilatation in the distributive shock. So that is failure of the sympathetic tone, as in the case of anaphylactic and anaphylactoid reactions and neurogenic shock. But in addition to this vasodilatation, in septic shock, there will be a endothelial damage. So there will be leak of the intravascular volume into the interstitial space. So coming to this hypovolemic shock, here it is concerned with volume, but the volume is lost. So it may be a blood loss or it may be body fluid loss in plasma loss. So blood loss as in the case of trauma or your PPH, or body fluid loss in the vomiting and dehydrations, diarrhea, dehydrations, and in plasma is in the case of burns. So ultimately the volume is lost. So there is hypovolemia. In cardiogenic shock, it is a pump failure. That is cardiogenic pump failure. It may be concerned with the myocardial pump failure. That is the problem may be with the myocardium, as in the case of myocardial infarction. And it may be in the conducting system. It may be a bradykardioarrhythmias, or it may be a pathology of the valves which decompensate. So it is a cardiogenic shock. So coming to the extracardiac or obstructive shock, there is a obstruction to the flow of the circulation. It may be a greater circulation or it may be lesser circulation. In case of a pulmonary embolism, it is concerned with lesser circulation, or it may be a pericardial effusion or tension pneumothorax. So obstruction of the blood flow to the lesser circulation or greater circulation is the extracardiac, or is otherwise called obstructive shock. So whenever hypotension happens, what is the normal compensation? In one limb, the baroreceptors get activated. So increased sympathetic activity stimulates the heart. Your heart rate and contractility increases. So increase the cardiac output leads to the try to maintain the blood pressure. In the other limb, what happens? The blood flow to the renal reduced. So renal perfusion reduced. So your RAA system activated. You can say RAA, AAA also you can say. Renin, angiotensin, aldosterone, and you can add ADH also. So what happens? The angiotensin is a powerful vasoconstrictor. It constricts the vessels and increases the systemic vascular resistance and try to restore the blood pressure. And aldosterone, what it do is it conserves the excretion of the sodium and water. So increases the circulating volume. So increases the preload. So it increases the cardiac output and try to restore the blood pressure. So this is the normal compensation whenever there hypotension occurs. So the hemodynamics, so what is the ultimate goal of your cardiac function? It is a perfusion of the end organs to meet the oxygen demand, and also energy substrate should be, that is glucose, should be supplied to the end organs. So already I discussed in the first class itself, the oxygen delivery. So oxygen delivery depends upon the oxygen content and its delivery by the cardiac output. So oxygen content depends upon the hemoglobin oxygen saturation, and your cardiac output depends upon the heart rate and stroke volume. So throughout the presentation, you remember this. Cardiac output is nothing but heart rate and stroke volume. So your heart rate depends upon the rate and rhythm, and your stroke volume depends upon preload, contractility, and afterload. The preload can be assessed by your CVP and afterload can be assessed by your MAP. So remember, blood pressure is nothing but the product of the cardiac output and systemic vascular resistance. The cardiac output is always inversely proportional to the systemic vascular resistance. Whenever the systemic vascular resistance increases, your cardiac output decreases. Whenever systemic vascular resistance falls, your cardiac output increases. So you remember this. Do you know what is Mary's law? In hypertension, there will be a reflex bradycardia, that is called Mary's law. So coming to the hypolimic shock, here the volume is circulating volume is lost. So what is the compensation? There will be a sympathetic volume is lost means your cardiac output is reduced. So the blood pressure is cardiac output is systemic vascular resistance. So the compensation is increase in systemic vascular resistance. So there will be increased systemic vascular resistance and your circulating fluid will be lost. So what is the pathogenesis of hypolimic shock? There is a dehydration due to loss of blood, body fluids or plasma that leads to the intravascular volume depletion. So circulating blood volume is reduced. So your venous return reduced. So your pressure in the venous circulation is reduced. So your JVP is reduced. And you remember the pressure is the product of the Q and R. Q is flow, R is the resistance. So here the resistance is the flow, flow is reduced because of the reduced blood volume, the flow is reduced. So the compensation, the R resistance is increased in order to keep the pressure constant. So what happens once the organ perfusion is reduced because of your hypovolemia? So irreversible damage occurs. What is irreversible damage? In skin, it leads to vasoconstriction and diversion of the blood from the skin to the vital organs. That is diversion of the blood from non-vital organs to the vital organs. The skin looks like cold, mottled extremities. So brain, so blood flow reduces. So cerebral ischemia eventually results in progressive loss of consciousness. So this is the end organ damage. So heart, there is a compensated tachycardia and further compromise will lead to pulseless electrical activity. In kidney, the blood flow is reduced. So renal ischemia ultimately leads to acute tubular necrosis and your reduced glomerular filtration rate leads to oliguria and ultimately the renal failure is the end organ damage. In all other organs, because of the short supply of the oxygen, anaerobic metabolism leads to formation of the lactic acidosis. So this is more important. You imagine when the heart stops, the vascular system, the venous system and arterial system is filled with certain amount of the blood. That volume of the blood is known as unstressed volume. So the pressure in the system is now, it is called minimum systemic filling pressure, MSFP. So when the heart starts, the stroke volume will be added to the circulating volume. So that volume is called stressed volume that causes stress on the walls of the vessels. So that increases the venous return and increases the cardiac output. So in hypovolemia, there is loss of stressed volume. So when you add high fluids, the stress volume increases. So your venous return increases and your cardiac output increases. The other way of increasing the venous return is you cause vasoconstriction of the vessels. You convert the unstressed volume to the stressed volume. So your venous return will be increased, your cardiac output will be increased by using norepinephrine. So the treatment of hypolimic shock, the first line of treatment, you give fluids in the form of blood, plasma and fluids. And second line of treatment is you go for norepinephrine when the systolic blood pressure falls below 90. So you know the mechanism, it converts the unstressed volume. It converts the stressed volume, unstressed volume to stressed volume. You'll see here. It converts the unstressed volume to stressed volume. So the venous return increases. So ultimately, by using a norepinephrine, you can resuscitate the patient with lower amount of the fluid. That is called, the norepinephrine acts as a fluid-like effect. It was published in the 2021 Journal of Critical Care. And when after a treatment with your IV fluids and norepinephrine, if you see the blood pressure is not restored, then you think of myocardial dysfunction. So the heart is not functioning properly. So then you go for inotropic agent like dopamine and epinephrine. So coming to the distributive shock, here there is the intense vasodilatation. In sepsis, in addition to the intense vasodilatation, there is the endothelial damage. So there will be leak of the fluid from the intravascular to the extravascular compartment. So the pathophysiology in distributive shock is, it occurs in pancreatitis, anaphylaxis, sepsis. This is due to systemic inflammation. So the whole endothelium will be distracted. So there will be leak of the fluid from the intravascular to the extravascular compartment. And there may be vasodilatory drugs, that is nitroglycerin or calcium channel blockers, can cause vasodilatation. In liver failure, the vasodilators metabolism will be lost. So the circulating vasodilators will be increased, so cause vasodilatation. In arterial insufficiency, if you remember, the cortisol is the one drug that sensitizes the catecholamine receptors, that is alpha receptors and beta receptors, to the circulating catecholamines. If it is absent in case of adrenal insufficiency, the sensitivity of the catecholamine receptors, that is alpha receptors and beta receptors, to the circulating catecholamines will be lost. So that will cause vasodilatation. In neurogenic shock, when there is an injury to the cervical and thoracic spine, below that level, the sympathetic innervation will be lost. So that will cause vasodilatation. Suppose the injury is above T4, the cardiac sympathetic fibers will be lost. So that will lead to bradycardia and hypotension. So coming to the distributive shock, the effect of distributive shock is, here due to the vasodilatation, the extremities will be warm. And due to the vasodilatation, you already know the blood pressure is cardiac output and stroke volume. Your cardiac output will be increased as a compensation to restore the blood pressure. So cardiac output increased means your systolic pressure increases. At the same time, the diastolic pressure falls, because the diastolic pressure is maintained by your systemic vascular resistance. Now, systolic BP is high, diastolic BP is low, so you get a wide pulse pressure. So that you get a bounding pulse. So warm extremities, low BP, bradycardia only in the case of neurogenic shock involving the cardiac sympathetic fibers. Otherwise, you will get tachycardia. Then bounding pulse. So these are the features of the distributive shock. Once again, when the distributive shock leads to reduced organ perfusion, the end organ damage will occur. Brain, loss of consciousness, heart, myocardial ischemia, kidney, there will be renal failure, and all other tissues, there will be lactic acidosis. So you get tachycardia, reduced JVP, and your wide pulse pressure. So septic shock, in septic shock, there will be a distributive shock. There is a bacteria that releases endoxin. Endoxin is nothing but the lipopolysaccharides that induces a series of reactions which results in the low perfusion pressure. So we will see what is the sequence of events that happens. This endoxin causes damage to the endothelium and releases the vasodilators, locally active vasodilator, nitric acid, that causes vasodilatation. Then it acts through the complementary pathway through the mast cell, it releases histamine and causes further vasodilatation. And it acts on the macrophages and neutrophils and release the inflammatory reactors, that is cytokines and interleukin 1 and 6, that acts on the endothelium, and the endothelium also releases the plasminogen-like activators that interfere with the coagulation. So these are the pathophysiology of septic shock. So the vasoactive agents we are used in the septic shock is, we use the alpha receptors. So these are the drugs we use which acts through the alpha receptors. First line is norepinephrine, second line epinephrine, third phenylephrine, fourth is the dopamine. Then dopamine higher doses acts through the alpha receptors, lower doses it acts through the dopamine 1 and 2 receptors. And then your vasopressin that acts through the vasopressin 1 and 2 receptors. And your angiotensin 2 that acts on the arginine vasopressin receptors. And it also acts on the posterior pituitary and releases the vasopressin. In addition to that, we are using steroids, because steroids sensitizes all these receptors to the circulating catecholamines. So coming to the cardiogenic shock, here there is a pump failure, that is effective cardiac contraction is not there. So already I told you, blood pressure is cardiac output into systemic vascular resistance. When cardiac output reduces, your systemic vascular resistance increases. So there will be sympathetic stimulation and there will be intense vasoconstriction. So the pathophysiology is the cardiogenic shock can occur in arrhythmia, in valve dysfunction, cardiomyopathy, and myocardial infarction. So in arrhythmia, what happens? It may be a bradyarrhythmia or it may be a tachyarrhythmia. If it is a bradyarrhythmia, what happens? You know, the cardiac output is the product of the stroke volume and heart rate. When heart rate reduces, your stroke volume is reduced. Your stroke volume reduced. In tachyarrhythmia, what happens? The diastolic time is reduced. So diastolic filling is reduced. So your stroke volume will be reduced. So ultimately, your cardiac output will be reduced. In cardiac wall dysfunction, there will be regurgitation and stenosis. Regurgitation, during systole, there is a backflow. So the stroke volume is reduced. In stenosis, the forward flow is obstructed. So your stroke volume reduced, your cardiac output reduced. In cardiomyopathy, there is outflow obstruction. So your stroke volume reduced, your cardiac output reduced. And your myocytic dysfunction and myocardial infarction, there is death of the cardiac cells. So your contractility will be reduced. Contractility will be reduced means your stroke volume reduced. Then your cardiac output reduced. So when cardiac output is reduced, your stroke volume is reduced. Sorry, your cardiac output is reduced, your systemic vascular resistance automatically increases. So in cardiogenic shock, you have low cardiac output, high systemic vascular resistance. So this is the effect of end organ damage. So the brain, loss of consciousness, heart, there will be a myocardial ischemia and pulseless electric activity. Kidney, there will be renal failure. In skin, there is diversion of the blood from the skin to the vital organs. And in the right ventricular backflow causes congestion of the venous system. So JVP will be increased, your distended neck veins, and there will be peripheral edema in the extremities. In left ventricular failure, your pulmonary capillary wedge pressure will be increased. So there will be leakage of the blood from the pulmonary vasculature that lead to pulmonary edema, then end up in dyspnea and tachypnea. So coming to the last, that is obstructive shock. In obstructive shock, there are three types. That is cardiac tamponade, pulmonary embolism, and tension pneumothorax. So in cardiac tamponade, what happens? There is a fluid around the heart. So the ventricular filling will be reduced. So the venous return also reduced and ventricular filling is reduced. In pulmonary embolism, the obstruction is between the right ventricle and left ventricle. So for right ventricle, the afterload will be increased. For left ventricle, the preload will be decreased. So what happens? There will be a reduced cardiac output in the form of left ventricle and the right ventricle. So in tension pneumothorax, the thoracic volume is increased. So that means venous return decreased. So their cardiac output decreased, where blood pressure is decreased. So all lead to the end organ damage like loss of consciousness, pulseless electric activity, and renal failure. So if you know now all the pathophysiology of the four shock, now you can come to the, you can yourself, you can say what will be the treatment for each shock. So in cardiogenic shock, I already told you there is a pump failure and intense vasoconstriction, compensatory systemic vascular resistance increased, so intense vasoconstriction. So what drug you have to give for cardiogenic? There is a heart failure, you give a drug that increases the contractility, that is nothing but inotropes. Then you have to give a drug that causes vasodilatation, because your cardiac output can be increased only when the systemic vascular resistance is decreased, because cardiac output is equal to stroke volume into your systemic, blood pressure is cardiac output into your systemic vascular resistance. So to increase the cardiac output, you have to reduce the systemic vascular resistance. So the drug you have to use is ionodilators. That means it causes effective contraction of the heart and at the same time cause vasodilatation, thereby reduces the afterload. So that is the drug. Ionodilator is the drug of choice for cardiogenic shock. In distributive shock, I already told you, distributive shock, there is intense vasodilatation. So the drug you have to use is vasoconstrictor, whether norepinephrine or epinephrine. In hypovolemic shock, already we have seen, that is you have to replace the fluids, body fluids, or it may be a plasma, blood, or eye fluids. If it is not responding, you have to go for a norepinephrine, vasoconstrictor. Then coming to the distributive shock, here there is obstruction to the outflow of the blood. So you have to remove the obstruction. What is the obstruction? Pericardial effusion. You have to do pericardiocentesis. If the obstruction is in the pulmonary embolism, you have to go for a thrombolysis. If the obstruction in the pneumothorax, you have to go for a needle decompression. So this is the treatment for the obstructive shock. So now coming to the determinants of the effective tissue perfusion. What are the factors that determine the tissue perfusion? For the effective tissue perfusion, your cardiac performance should be good, like cardiac function, and your venous return should be adequate. And your vascular performance, that is tone of the vasculature, should be adequate to transport the blood from the heart to the end organ. And in the end organ, the microvascular function also should be normal. Then the blood has reached the end organ. Now the oxygen has to be unloaded from the hemoglobin and has to diffuse into the cell. In the cell, the energy metabolism, that is oxidative phosphorylation, should be done adequately. So cardiac performance, I already told you, depends upon the preload, contractility, and afterload, which depends upon the stroke volume and heart rate. So the cardiac output along with peripheral resistance determine the blood pressure. So this is the auto-regulation. So our auto-regulation depends upon the two mechanisms, that is myogenic hypothesis and metabolic hypothesis. What do you mean by auto-regulation? So the infusion, that is your perfusion pressure is maintained at normal level even at high blood pressure and low blood pressure. So that is called auto-regulation. This plateau phase is called auto-regulation. So myogenic hypothesis, whenever the pressure is high, it causes vasoconstriction by constriction of the smooth muscle of the vascular smooth muscle. So reduces the blood flow to the end organ. Whenever there is hypotension, this myogenic hypothesis dilates the vascular smooth muscle and increases the perfusion of the end organ. So this is the auto-regulation. Another auto-regulation is metabolic hypothesis. It acts after the precapillary sphincter. It depends upon the oxygen delivery and consumption by the cell and metabolic product carbon dioxide, hydrogen ion, potassium ion, lactate, and adenosine. We will see it later. So the auto-regulation for cerebral is 50 to 150. In heart, it is 70 to 110, but there is no defined auto-regulation for the coronary circulation. Blood flow is independent of BP. So kidney, there is intrarenal auto-regulatory mechanisms to maintain the renal blood flow and also your GFR. So it maintained at 80 to 180 mm of mercury. It is the auto-regulation of the kidney. So microcirculation, so up to the arterioles, your auto-regulation works. So the precapillary vessels are called resistance vessels, post-capillary vessels are called capacitance vessels. So up to the arterioles, your auto-regulation works. So after the arterioles, in the meta-arterioles, the precapillary sphincters determines the flow to the capillaries. So the precapillary sphincters rhythmically opens and closes. So that movement of the blood is called vasomotion. So this precapillary sphincter is under the control of metabolic hypothesis, that is oxygen in the partial pressure of oxygen in the end organ, and also metabolic products determine the tone of these precapillary sphincters. So coming to the vascular failure. So what are the causes that cause the vascular failure? Vascular failure means fail to transport the blood from the heart to the end organ. So the vascular failure is due to the tissue acidosis, local vasodilatation it causes, and your catecholamine depletion. So in shock, there will be increased secretion of the catecholamines. So there will be exhaustion of the catecholamines, and overexposure of the catecholamine receptors, that is alpha and beta receptors, cause downregulation of the alpha and beta receptors, and also there will be resistance of the catecholamine receptors to the circulating catecholamines. So the third thing is endogenous vasoactive substances. Whenever there is increased blood volume, brain natriuretic peptide will be secreted by the left ventricle. So what it do is it causes vasodilatation and it facilitates the excretion of the sodium and water by the kidney. Then the atrial natriuretic peptide, this is secreted by the atrium cause vasodilatation and facilitate the excretion of the sodium and water to reduce the volume overload. So then the C-type natriuretic peptidase, it is in the endothelium. It also locally causes vasodilatation. So the decreased sympathetic tone. So whenever the sympathetic tone is lost, as in the case of distributive shock, so there will be a vascular failure. And whenever there is a endothelial damage, there will be local release of nitric acid that will cause vasodilatation. So these 5 factors determines the reasons for the vascular failure. So vascular failure is nothing but failure to transfer the blood from the heart to the end organ. So other determinants are, once the blood has reached the end organ, the oxygen has to be unloaded from the hemoglobin and diffused into the cell. So the unloading is more important. That is ODC, shifting of the ODC to the right side. That is, we have to decrease the affinity of the hemoglobin to the oxygen. So that is by the increased 2,3 DPG and blood pH and also increase in temperature. Once it reaches the cellular cell after diffusion, the cellular function should be active. That is, the oxygen should be metabolized through the citric acid cycle, that is oxidative phosphorylation to produce ATPs. So these all things has to be intact for a effective perfusion, tissue perfusion. So the oxygen extraction ratio, I have told you this in the first class itself. The oxygen extraction ratio normally is 25%. That is 1000 ml oxygen is supplied to the end organ. Only 250 ml will be taken by the end organ. 750 will be returned to the venous system. So this extraction ratio is why 25%. It is a reserve capacity. Whenever there is a increased exercise or increased demand of oxygen, this extraction can go up to 50 to 60%, independent of the delivery of the oxygen. So you have to remember, independent of the delivery of oxygen, it can go for extraction of 50 to 60%. That means 500 ml of oxygen can be utilized by the cells. But when it go beyond 60% extraction, then it becomes delivery dependent. So you have to adequately perfuse the end organ to get the oxygen extraction. So this is the end damage of the cell. The cell due to the damages due to cellular ischemia, free radical formation, and your local inflammatory mediators. These all cause the damage to the end organ. So coming to the management of the shock, the initial therapeutic steps is you admit the patient in the intensive care unit, to IV access, start central venous catheter, arterial catheter, EKG, that is ECG monitoring, pulse oximeter monitoring. Then you support the hemodynamic. How to support the hemodynamic? First, you do a fluid challenge, whether the shock can be reverted by giving the IV fluids. So you do a fluid challenge. Suppose the fluid challenge fails, means there is a failure of the vascular system, or it may be failure of the heart. Then you have to go for a vasopressors or inotropes. So that is the basic methodology of treatment of the shock. So your goal should be, hemodynamic support should be, you have to maintain the MEP more than 60, pulmonary artery occlusion pressure 12 to 18, cardiac index more than 2.2 liter, maintain oxygen delivery by increasing the hemoglobin, artery saturation should be increased by means of supplementary oxygen or your mechanical ventilation. Then you have to reverse the lactate production. How to reverse the lactate production? That means anaerobic metabolism should be converted to aerobic metabolism. You have to adequately perfuse the organ with adequate oxygen. You can convert the anaerobic metabolism to aerobic metabolism. Then maintain urine output, reverse encephalopathy, improving renal and liver function test. So the resuscitation, you have to give crystalloid or colloid. So it is a controversy is there, but the crystalloid is preferable. Then optimal pulmonary capillary wedge pressure is 10 to 12 or 15 to 18. There is a controversy. Then you do a fluid challenge. That is, fluid challenge is 20 ml per kg fluid, or 250 ml should be given in 10 minutes. Then you see for a rise in stroke volume. In olden days, we will see for the rise in systolic blood pressure of 10%. But now they say only you have to look for the stroke volume rise of 10 to 15%. Suppose there is no response, then you can go for 5 to 10 ml. Repeat challenges. in case of cardiogenic shock, we have to challenge with low volume, that is 100 to 200 ml. But this fluid challenges, nowadays they are not following fluid challenges. Do you know why? Because only 50% of the patients improve after the fluid challenge. So that means 50% of the patients are having some other than the fluid, that is cardiogenic shock, or it may be a vascular failure. So this 50% patients who are not improving after the fluid challenge, this fluid challenge will be detrimental to the patients. So they are avoiding the fluid challenge. Now they go for a slow leg raising test in ICU. Do you know how to do the slow, that is passive leg raising test? You have to sit the patient in 45 degree and you have to tilt the patient flat with the limbs raised. So what is the advantage of this passive leg raising test? Mean you are not additionally giving any fluids. You are only shifting the fluid in the vascular system. When you keep the patient in 45 degree, the upper part blood will get pulled in the lower limb. When you raise the leg, the lower part blood will go to the upper limb, that is heart. So that is a better, safe challenge of fluid in the form of passive leg raising test. So whenever you go for a fluid challenge test, when the patient is cardiogenic or patient in the vascular failure, there will be detrimental to the patient. So we better go for a passive leg raising test. So coming to the role of vasopressors and inodilators in the shock. So this is the proposed classification. So the drugs with inotropic effect and vasoconstrictors are norepinephrine, epinephrine, and dopamine. Only vasoconstriction effect is phenylephrine and vasopressin. The drug with inotropic effect with vasodilatation is dopamine and milrinone, and only vasodilator is nitroglycerin, nitroprusside. So you must know the receptors where it is present and what is the action of the receptors. So alpha, it present in the vessels, it causes vasoconstriction. Beta 1 present in the heart, it causes positive inotrophy and coronotrophy. Beta 2, it present in the blood vessels, cause vasodilatation. Dopamine D1 present in the D1, D2 present in the splanchnic vessels and kidney, cause vasodilatation. Vasopressin 1 present in the blood vessel, cause vasoconstriction. Vasopressin 2 present in the kidney, cause antidiuretic effect and vasodilatation. Angiotensin 2, it acts in the posterior pituitary and release vasopressin, and it acts in the kidney, causes vasoconstriction, and norepinephrine, vasopressin release from the posterior pituitary. So you must know which inotropes acts on the which receptors. So norepinephrine predominantly acts as alpha receptors. Epinephrine acts 50% in the alpha and 50% beta. Dopamine, it is a dose dependent. Low dose, it acts on the dopamine. Intermediate dose, it acts on the beta, and high dose, it acts on the alpha. Vasopressin, the advantage of vasopressin is it not acts through your normal catecholamine receptors, that is alpha and beta. It acts through the vasopressin receptors V1 and V2. Phenylephrine acts through the alpha receptors. So these are the receptors found in the blood vessels, that is alpha 1 receptors, beta 2 receptors, then your arginine vasopressin receptors, dopamine receptors, and angiotensin receptors. So you know these receptors are present in the vascular smooth muscle. So you have to select a drug accordingly to cause a vasoconstriction in case of the shock. So this drug effect, here I have grouped the drugs according to the alpha and beta effect. Middle is the epinephrine. That means it has a 50% alpha effect and 50% beta effect. If we move in the right side, it has more beta effect. So isoprenylene has more beta effect. Left side, phenylephrine has a more alpha effect. So norepinephrine acts both alpha and beta. It is considered as the first line of vasopressor after the SOAP 2 trial. So it is advised by the surveying sepsis guidelines as the first line of vasopressor. Previously, dopamine was advised. Now it is removed because of the side effect like arrhythmogenic. So it is dopamine is arrhythmogenic. So they have removed the dopamine. Now the noradrenaline is the first line of vasopressor in sepsis. So how it acts? Norepinephrine, alpha receptors and beta receptors. In alpha receptors, in venous system, it increases the vasoconstriction and increases the preload. In arterial side, it increases the coronary perfusion pressure and increases the afterload and increases the contractility, and it increases the stroke volume. Increases contractility mean through the beta-1 receptors. Beta-1 receptors, it increases contractility and increases the stroke volume and cardiac output. So this is interesting. You see, norepinephrine in the lower dose, that is 0.1 to 0.5 microgram per kg per hour, its vasoconstriction effect is linear, and there is a reflex bradycardia. Now, when the dose exceeds 0.5 microgram per kg per minute to 2 microgram per kg minute, it lost the linear effect of the vasoconstriction effect is lost, and there is a stimulation of the beta-1 receptor starts. So that means beta-1 receptor starts means that produces tachycardia. Your reflex bradycardia is overcome by this dose. Now, when you further increase this dose to beyond 2 microgram per kg per minute, then what happens? Your beta-2 receptors get activated, and your beta-2 receptors cause vasodilatation. Beta-1 receptors increases systolic blood pressure, so there will be a wide pulse pressure. So any further increase in the dose of noradrenaline beyond 7 microgram per kg, there will be intense vasoconstriction. You know, when there is intense vasoconstriction, that is intense increase in the systemic vascular resistance, your cardiac output will be reduced. So any number of increase in the dose of noradrenaline beyond that will not increase your blood pressure. So that is the end. So epinephrine, if you take epinephrine, it acts differently in septic shock and also the cardiogenic shock. So in septic shock, it acts as a vasoconstrictor. In cardiogenic shock, it acts as a ionodilator. How? So in septic shock, what happens in moderate dose? In septic shock, already you know there is a intense vasodilatation. So in moderate dose, your beta-2 action is abolished. In high dose, your alpha action will come into play that increases the systemic vascular resistance. So it acts as a vasoconstrictor. In cardiogenic shock, what happens? In cardiogenic shock, already the peripheral vascular resistance is high. So your alpha-1 effect is lost. So the remaining effect is the beta-1 and beta-2 effect. You know, beta-1 increases the cardiac output, tachycardia, and increases the stroke volume. And your beta-2 causes vasodilatation. So increased cardiac output, vasodilatation means it is acts as a ionodilator. So dopamine, it acts on alpha-1 receptors, increase stroke volume, beta-1 receptors, increase heart rate. So ultimately increases the cardiac output, where beta-2 action causes vasodilatation. So in high dose, it acts as a dilator. So dopamine is a dose-dependent activity. I already told you it is removed from the first line of vasopressor from the septic guidelines. In low dose, it acts in the dopaminergic receptors, intermediate beta, and high doses it acts on the alpha receptors. So what are the vasopressors used in cardiogenic shock? So whenever in cardiogenic shock, restoring the blood pressure is your first line of management, you go for a norepinephrine. The ideal ionodilator for a cardiogenic shock is the dopamine. The second line of ionodilator is the milrinone. It improves the hemodynamic acutely, but long-term safety is not known. Second line of treatment is levisimendan. It acts through the calcium sensitization, and it vasodilates by opening of the potassium channels. So European Society of Cardiology recommends levisimendan as a drug of choice for low output cardiac failure secondary to systolic function. But levisimendan is contraindicated when systolic BP is less than 85. So what inotropes vasopressors should be used in cardiogenic shock? When blood pressure needs to be restored, first you go for a norepinephrine. Dopamine is the first line of inotrope. Levisimendan, second line of agent when the patient is already taking beta blockers. So vasopressin, so interestingly, vasopressin acts through the vasopressin receptors. So whenever there is a failure of the catecholamine receptors, you go for vasopressin. You can get additional benefit when you combine vasopressin along with your catecholamine. See, vasopressin has a little effect, but above the noradrenaline effect. When you combine both, you will get a additive effect. But always remember there will be chance for gut ischemia whenever you use vasopressin. So angiotensin 2, it is approved by FDA for a high output shock after the trial of Ethos 3 trial. It restores the cardiac index more than 2.3. It is better used along with norepinephrine. So this methylene blue and hydroxycobalamin are successfully used for the treatment of the vasoplegic syndrome after cardiopulmonary shock. Cardiopulmonary CB, cardiopulmonary resuscitation. So methylene blue and hydroxycobalamin, only the case reports are available. Randomized control trial are not available. So it is not included in any of the guidelines. It is only in the experimental level. So in summary, first you must understand the pathophysiology of the shock. Then you have to select the vasopressor according to the receptor's preference. First you select a vasopressor according to the guidelines. The second additive vasopressor should be according to the patient's receptor's responsiveness. So with that, I come to the end of my presentation. This is my blog. Continuous teaching will be there in the anesthesia blog. Thank you. Thank you, sir. Over to you, sir.
Sir, excellent presentation. Both useful for postgraduate curriculum as well as practical. Especially the rotating of fluid challenge test. We also are using leg raising test because if we any problem with the increase in volume, we can bring the leg down and the volume will go back to the leg. So it is highly reversible. Once you push the fluid in, it's very difficult to take it out. And ceiling limits of noradrenaline all were very useful, sir. Thank you very much, sir.
You
And
can
one
go to
query.
the next session, sir. I will post the answers in the chat box.
Yes, sir. Okay, sir. So we have talked a lot of theory and practical things. Let us next see a video on how to measure the blood pressure to understand both cardiac physiology and treat shock.
Invasive pressure monitoring is an essential part of anesthesia and critical care. By pressure, I mean can be a vascular pressure or central nervous system like CSF pressure or a compartmental pressure. The pressure is measured using a transducer, and this is the heart of the pressure monitoring system. This transducer converts the mechanical energy into an electrical energy. Here, the arterial pressure is the mechanical energy and it is converted by the transducer into an electrical energy and is displayed on the monitor in useful numbers so that we can interpret it, and also the waveform is also displayed.
So what are the components of such an invasive pressure monitoring system? We have three components. First is a rigid pressure tubing that conducts the mechanical energy from the patient to the transducer. Next is the transducer, which can convert this mechanical signal into an electrical signal at this interface, and an electrical system to the wire. It conducts the electrical signals here to the monitor. This monitor filters it, it evens the waves that are produced here, and it will show a numerical wave as well as a waveform pattern. Part of all that, the pressure monitoring system is this transducer. This transducer becomes the interface between the mechanical energy which comes from the patient, which is converted into an electrical signal and goes to the monitor, as we have already said. This interface consists of a patient end, atmospheric end, a flesh end, and you can see a black dot inside. This is the actual Wheatstone bridge or a strain gauge, which converts the mechanical signal into an electrical signal. So I'll just show you how all these connection tabs work. So the first is the flush end. This is guarded by a flush valve. This is a rubber valve which is tightly sealed. I use a saline which will not fill here. See, even if you press, it will not fill. Now, when I just pull this, it will come out. So this is a very tightly sealing valve, which will not allow the high pressure flush to come inside it or have its effect on the transducer. So the other two are, one is the patient end. This is always in a male end. This is the male end of the tab which has a screw. You will have to put the arterial line and connect the female end of that connection tube into the male end. The female end is called the atmospheric end, and it is guarded by a three-way stopcock. Wherever the three-way stopcock points, that it is closed now. So this is the transducer is actually open to the atmosphere now. This is the connecting used to connect the patient and the transducer. These tubes are usually and after seeing this is the thing. The material difference that it's a soft material, very complex, very thin, and the diameter is very small, whereas the diameter is very big. Only this type of tubes should be conduct all this pressure waves to the transducer. It's commonly called as alien and not. And in this tubing, you can see that there is one alien and an alien. The male end will usually fit the artery catheter, and the female end will fit into the patient end of the transducer. This is how it is done, and it is filled with the non-compressible. Usually, the reference ring stress of flush will be filled. There are two properties that are very important when tubes considered. The first thing is called natural frequency. Suppose if I give a small tube vibrates stops. The frequency of this oscillation is called its natural frequency. Usually, it's designed so that the natural frequency is well defined itself. Main reason is that the vascular system has a frequency of 1 to 2 hertz. Any soft tube or is very long. When match this frequency, then when conducting this pressure waves, these tubes would start to resonate. I tell it again. See, if our vascular system has a frequency of 1 to 2.7, if this tube matches this frequency, this will resonate and will start producing something called ringing. Ringing means the natural pressure waves you see. These waves overlapping, that is called undertapping. So when you want to avoid this phenomenon, you should use small tubes of a thicker diameter, thicker size. Only then this wave will be conducted without loss of energy. The first step in setting up this transducer is take a normal saline, a plastic bag or a bottle, add 5,000 units of heparin to it. So this heparin will keep this arterial system clot free. So you have to add 5,000 units in this 500 ml. The next important step what you have to do is completely de-air the system, because we are going to pressurize this saline and this tubing, and this pressure will be transmitted into the transducer and to the patient. So any small error will cause a lot of air to enter into the artery, radial artery or whatever artery it is. So what you have to do is invert this, open the system and remove all the air. You can see all the air is coming out. Now I have completely de-aired the system. The bag, this tubing, even this air chamber will not contain any air. So now you will have to insert this into a pressure bag system. I have inserted this, hang it on a stand, and you have to inflate the pressure to 300 millimeters of mercury. So when you this should at least be a little bit higher than the arterial pressure. So what we do is, here also it contains a stopcock. Turn it towards here. You can see here there is a pressure monitoring system here. Slowly it's rising. Because it's a collapsible bag, it takes slightly more time. And now it's at 300 millimeters of mercury. Close this. If I just open this, you can see fluid will jet out. And now I'll have to connect my transducer's flush end. I've already told you this is the flush end to this flush system. And if I slightly open this, automatically all the air in the system will come out. So it has all come out. So completely my flush system has de-aired the transducer. Now I have to connect the connecting tubing to the patient end. This is the female end. I'm connecting it to the patient end, tightly tapping it and change the previous torque towards the patient end, and again de-air. So you can see it has come up. There is no air from the pressure bag system, the transducer, and to the connecting system. There is not even a single bubble of air in it. Next, what we will see is what all should you do in the monitor. So this monitor has two channels for recording invasive blood pressure. The first channel I have labeled it as arterial line. So what you should do is you check where the label goes. Suppose you want something else, you can also record a pulmonary pressure, CVP, right atrial pressure or left atrial, whatever you want. You have to change the label so that the scale is proper. And from here, you have to go to the settings and set the scale. So if my patient is a hypertensive and the higher limit is 180 or 200, I'll have to go there and I have to adjust the scale. So here, the upper part of the scale for the channel on arterial line is 160 and the lower is 0. I'm increasing the upper part a little bit so that I can see the waveform properly. And the lower limit is 40. So any scale you can set from 0 to 300, or if it is a CVP, even if you can even set it to negative values also. Proper adjustment of the scale will show you the waveform clearly. Next, we will see how to zero this monitor. So to zero this monitor, what I will have to do is, I will have to turn the stopcock and close the patient end. So now I have turned the stopcock and close the patient end, and now transducer is open to the atmosphere. The flush is also closed. So first to de-air this whole system by pulling the flush. You can see the saline is coming out and all the air bubbles in the transducer system is gone out, and now this transducer is directly exposed to the atmosphere. And now go to the monitor. In the monitor, there will be a way to zero the transducer. IBB pressure 0, channel 1 is 0. Press it for some time and it will show as channel 1 successful 0. You can see that this monitor is now recorded the atmospheric pressure as 0 and it is ready to measure the patient's pressure which is above the atmospheric. I have inserted 20 gauge arterial cannula into the radial artery of the patient after an Allen's test, and now we are going to connect this patient to transducer. The main end of the transducer connecting line is now connected to 20 gauge cannula.
So after zeroing the transducer and connecting to the patient, the next important step is leveling. The leveling is important because to measure the intended vascular pressure, we should keep the transducer at the intended level. So for example, for systemic vascular pressure, the chosen site is aortic root or arch of aorta, which is at the point 5 centimeter below the sternum. So the external marker for this is the mid-axillary line and the fourth intercostal space junction. This is called the phlebistotic axis. So now we have set the transducer at the level of the phlebistotic axis, here exactly at the fourth intercostal space and the mid-axillary line junction. So now the transducer is showing the aortic root pressure, which is 128/70. At this point, when the patient moves, height is move above or below the transducer, or the transducer is moved above or below, there will be a change in the pressure shown. For example, if the transducer is raised 10 centimeters above, or below, there will be a change of 7.4 millimeters mercury in the reading. So now I'm going to raise the transducer 10 centimeter above the physiostatic axis, and let's see what happens. So now in the reading, the systolic pressure has dropped from 127 to around 115. So now even if we move the arterial line, there will be no change in the BP, but the change in height of the patient or the transducer will produce a change in the
zeroing, leveling, enough to reproduce an actual pressure waveform or the numbers which a patient has to monitor. Those two are not clearly enough. We need one more factor called the dynamic response. So to test the dynamic response, what you have to do is you will have to either allow the transducer to experience the flush pressure, or you can use a small switch, attach it to the atmospheric air, close the patient end, and give a small pressure on it. So when you do this, you can see that the monitor have a small waveform. Square waveform goes up and comes down, right? Goes up and down. And after this waveform is created, you have to at least have one or two oscillations under there. It's called a fast flush test. So if the two oscillations are there, it means that the system is adequate in damping it. That is, the system is neither over damped or under damped. See, this is a run of normal waveform. I'll show you if the tube becomes very small, there can be sometimes an under damping. See here, can you see those distortions? So these are under damped waves. All the echoes, small vibrations in the vascular system, everything will be shown in this. If this under damping occurs, what happens is the systolic pressure will be overread. If the normal pressure, you can see that sometimes 136 is coming. The normal pressure is 180, 120. It will add 20 or 30 more to this and it will show distorted waves. At the same time, if you want to see the effect of over damping, introducing a small bubble into the transducer system will over damp. Yeah. See, this is a over damped wave. The characteristics of all the systolic upstroke, the dichrotic notch, everything is gone and the BP has come down. So if I remove the air bubble again, you will get the normal. So this is the normal wave. So to test this dynamic response, you have to do the fast flush test. And in fast flush test, after the square waveform, only two oscillations should be there. If it is not that there are more oscillations, you will have a under-damped system. If there are no oscillations, you will have a over-damped system and the waves will become characteristic. So in addition to zeroing and leveling, you should check the dynamic response of the system also. So I think you would have all understood how to set up this transducer and effectively measure arterial CVP. One thing I have to add is the phlebostatic axis acts as the reference point both for arterial pressure as well as the venous pressure, because the right atrial level is at this level only. So we can set the transducer stand at that point and accurately measure the arterial as well as the venous pressure. Thank you.
Thank you, Sivaprasath sir.
Thank
For
you, sir.
wonderful demo. I think we have to take the theory part also for this arterial intra-arterial measurement in our future classes. Thank you, Azam sir. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir. So with that, we will come to the end of this our edition. So we will meet next week. Next week program will be only 1 hour because of the Tamil Nadu ISA program. We cut short the program to 10 to 11. And after that, our program will be 2 hours. Thank you for all the participants. Thank you, Ananda.
Thank you, sir.
Thank you, A1 Logics, Shilpa. Thank you. We will wind up. Thank you. Thank you, Shilpa.